So Deanna asked me to speak about this topic and specifically about what to do beyond surgery and medication and the whole topic of radiation. And I'm not a radiation oncologist, but I am a gamma knife specialist, which is one, as you'll see, one form of radiation that is multidisciplinary in nature, and every gamma knife unit around the world involves a neurosurgeon and a radiation oncologist. And I've been doing that since 2005. The unit in Toronto was the second unit in Canada, and there are still very few units, but I'm speaking to you from that perspective. I told you about this, our experience with surgery. That dates back a long time. And I'm going to focus mostly on the gamma knife aspect, but I'll talk a little bit about the radiation. And my sense is that this radiation has a bad connotation, that I don't think we're using it to its full capacity. And I think there are places where it can be life-changing and it can be extremely effective. And most importantly, it's actually economically much, much cheaper than expensive medication, and it doesn't give you the ups and downs like we just heard. I heard that some medication to some people can cost up to $600 a day. And so again, we have to be thankful for what we have in Canada. And we need to do more, but we need to be thankful. Here's a slide I showed you yesterday from the Endocrine Society, and these are the guidelines for management of acromegaly. And I talked to you yesterday about the surgery part and this whole aspect here. But often there's residual disease, and I know we need to do better in terms of surgery, but also medication. But in these guidelines, radiation is still there and is a very, very important part. Now, from the outset, it's important to realize, just like surgeries and medicines are not all the same, neither is radiation. And there are many different forms of radiation, and radiation has evolved dramatically over the last 40 years, just like medicine and surgery has. And so what we hear about, if it's based on data from the 1960s, 70s, and 80s, that's probably not very relevant to what I need to know today. And there can be different kinds of radiation. You could give it in one dose, you can give it in multiple doses. It can be more focused, less focused. There are different types of radiation. Photons you may have heard about, like gamma rays. Protons, other charged particles like carbon ions are starting to come up in Germany and Japan and the USA, not yet in Canada. And the type of delivery machine varies as well. And so you're going to get different accuracies on the different machines. So it's very important when we talk about radiation, what are we actually talking about? And then when we're looking at outcomes, remember we mentioned, and Jill just mentioned this, is what are the criteria people are using to say whether they're in remission or not, which has changed over time as well. So let's talk first about what we would call conformal 3D radiotherapy. This is more of the traditional kind, but has been modified greatly over time. And this is useful really when we have to give 30 treatments instead of one treatment, when we have a bigger tumor. And because it's bigger, it's involving things like the optic nerves. And the optic nerves are very sensitive. They've often been pressed on for a long time, so they're already suffering. If we give too much radiation to the optic nerves, they're going to get damaged. Just like if a surgeon goes in there and doesn't recognize them or pushes them around, they're going to get damaged. Okay? So, but it allows for high doses of radiation to be administered, and the way it can be done safely is that instead of giving all the dose on one day, we give a fraction of the dose each day. And that's why it's called fractionated radiotherapy. And this can be done very safely now, and it's effective in the right patient. So we need to choose the patient. Here's a group of 113 patients that was reported a couple years ago. And you can see the remission rates that they reported at 1, 2, 3, and 5 years. So in the first year, it's very little. It takes time for radiation to work. Opposed to surgery and medicine, surgery, you tend to see the effect right away. And then you have the most complications right away, whereas radiation takes time to work, and if you're going to get complications, they tend to occur later. But by 5 years, they were getting about 3/4, and these are the difficult to treat patients. But what about some of the side effects? Hypopituitarism, that's loss of the pituitary hormone function. So we're seeing it in about 1/4 to 1/3 of patients. Now, some of the patients already lost their pituitary function by fact of the tumor, and they're on replacement hormones like hydrocortisone. And so in those patients, this kind of effect is less important to that patient. Okay, so these were the predictors of getting a response. So the tumor size, the IGF-1 level, and the age. Those were important in predicting it. So how is that different from what we're hearing about? You must have heard about gamma knife and cyber knife. None of them are knives. What they are ways of delivering the radiation in a very focused way. And that technique I just showed you would give a wide beam of radiation, and usually they would give 5 or 6 of these, and where they overlap, you would be able to treat it, like I think you could see here. That's where the beams are. This is a heat map, so the darker, that's a darker dose. What happens with machines like gamma knife, which is a form of radiosurgery, we have lots of very, very narrow beams. And what we do is we overlap them. And where they overlap, the dose here can be very, very high, but the dose that the brain gets around here is actually extremely low. Imagine having a magnifying glass in a hot summer day. If you have it focused on a spot, you can burn a hole into the paper. If it's not focused, it doesn't do anything. So these are 200, in the gamma knife they have 201 beams overlapping. So this really changed the situation for the safety and delivering the radiation where you want, and giving a high dose to where we want the tumor to be. And so it has nothing to do with knives. The knife part is more of a marketing thing, I think, from the companies to say it's as accurate as a knife. But there are many similarities. To use it, you need to have a target, just like a surgeon needs to have a target. If you can't see where it is, or you're not sure, or it's too much scar tissue and you can't tell what tumor is or not, the target's going to get less focused, and then you lose some of the effect. So we want maximum effect to the tumor, minimum to the surrounding brain, and we do it by these different techniques where we do multiple beams. We weight the dose differently. We drop different doses into the tumor called isocenters, and we have bigger or smaller beams, and we can put plugs into the system so that it protects critical structures like the optic nerves. Now, you may have heard of other kinds of radiation, like the cyber knife is the same principle, but this machine keeps moving around, whereas in the gamma knife it's fixed, and I'll show you what we go through to do that. You may have heard of proton beam. We don't have any in Canada. There's going to be one being started at the Princess Margaret hospitals in the next couple of years. The proton beam is a special type of radiation where the beam is delivered and the dose is deposited at a specific depth, whereas that first slide I showed, the first technique I showed you, the beams go all the way through. And so this is not without complications either, because the brain around here is getting some, but it tends to deposit a high dose here. The problem is it's very, very expensive. It's limited. Units in the United States are popping up here and there, but so far we don't have any in Canada. And with this technique, you can treat bigger tumors and potentially younger patients. So that is expensive, though, and not very accessible, even to people in the United States. We used to treat another tumor in this region called chordoma and get it sent down, get the patient sent to the States. But in the last 10 years, the Ontario government stopped because each treatment was $250,000. Now that sounds like a lot, but in face of some of the medicine, and it's one treatment for your whole life, it's maybe not so expensive when I hear it's $600 a day. So the one that is dominant, I think, worldwide is the gamma knife, which is the technique that I do. And I'm going to bring you through just the process. It's an outpatient procedure, and it involves, obviously, first, there's a whole selection process. So every patient who gets referred to our unit, we review in a multidisciplinary conference every Wednesday morning. We will not accept anybody unless the patient's file has been checked carefully with a neurosurgeon, a radiation doctor. They would have already had to go through a pituitary clinic where there's an endocrinologist, a neuro-ophthalmologist, their pathology is reviewed. And then, only then, they would get a consultation, they'll get a discussion, and then on the treatment day, they'll come in at 7 a.m. and the surgeon will put on a frame, and then we will go for a CAT scan usually, and then we do some treatment planning, and then we do the actual treatment. So it's a day procedure. Now the latest form of the gamma knife has the option of not using the frame. We have a mask that we can develop. If we want high accuracy, the frame is still the gold standard. We can be within less than 1 millimeter accuracy on the frame. And so even though it's a bit painful to put it on and it looks like, you know, a spaceship or, you know, something out of a horror movie, Silence of the Lambs, I'm hearing. It's under local anesthetic, and it's actually after the first 10 minutes, 15 to 20 minutes, people tolerate it. And they get used to it. And when it comes off, they get headache, but it's usually a day procedure, as I said, and usually I ask people to take, we do it on a Wednesday, they go back to work on a Monday or go back to school or their normal activities. So they take a few days off. Once they have the frame on, as I said, we do a CT scan. It's not used just for pituitary. Pituitary in our Toronto unit is the least common reason we do it. We're very selective who we use it for in pituitary. I think in other centers throughout the United States, it's used more commonly. But we're selective, and I think our results are good, although I haven't those numbers for you today. There's a lot of behind the scenes that go on where we want to make the target to aim and then the radiation doses. And so there's a little bit of a break after the CT scan that the patient can have some breakfast and relax, and then they go into the treatment machine. During the treatment, people don't feel anything. It's like when you go for an x-ray, you don't really feel anything. And we have videos and audio that we can talk and listen to music, or you just fall asleep because you got there so early at a surgeon's hour. And you just come out and say, is it over? And then we take the frame off and you're watched and you go home. So it's a full day. It's safe. It's efficacious. Here's some results from a systematic review of about 1,000 cases can help almost about half of people. But it takes time for it to work. Doesn't help everybody. The hormone normalization on average takes 2 years, but it can be up to 8 years. You can get late recurrence like any disease. The tumor biology is still critical. And usually we give specific doses. I'll show you a little slide about stopping medical therapy. Usually we want to stop any medicines about a month before. And there's a lot of variability in the results you can see down here. Some centers reporting 100% response and other centers reporting down at 10. So I think there's a lot of selection that's going on. Some centers are very selective like ours, and our results are higher, but maybe we're not treating as many patients as maybe who might benefit. So there's a trade-off. So here's an international multi-center study where they looked at 379 patients for 79 months. And their remission was 59%. And it took about 38 months to get it. And the only predictor of getting response was if they went off the medication beforehand. And they reported, again, the loss of pituitary hormones in about 26%, which is better than the old radiotherapy, much better. And cranial neuropathies in 4% of patients. And this is an international collaborative, so there's a lot of different techniques of the ways that people are doing things, and it's all lumped together. So here's this international society where they brought together over 1,000 patients. It's very effective at stopping the tumor from growing. If tumor growth and pressure things are an issue, that it can do extremely well. Remission rate, similar to what I showed you in the 44%, and the loss of hormones about 17%. And they had similar issues about control. Again, the smaller the tumor, okay, the less the amount of invasion, the dose that we can give, those are all important factors. So each person has to have their particular case looked at individually. Just like when you go for a surgery or you go for medical therapy, it's very important that the doctor look at, and the team, not just the doctor, but you look at what is it for my particular situation. You don't want to hear about 1,300 patients. You want to hear about you specifically, how your tumor is, and that's why the center's experience is very important to kind of say, okay, well, there are 1,300 patients there. Am I more in this group, or am I more in the 56% group? So you can make an informed decision with the team. It's really important. So we've heard about things about stroke. I've heard in talking to people, well, am I going to get a stroke? There's a worry about stroke out there. This was a study looking at over 4,000 patients, and they looked at ischemic stroke, which means a lack of blood flow to the brain after radiation. And this was all forms of radiation. And these were patients who were followed up for a long time. And the rate ranged from 0 to 11%, and the average was about 7%. Now, there were 4 studies in that with this kind of stereotactic radiosurgery, what I mentioned, and most of them were gamma knife, and they found no ischemic strokes. And that's been our experience in Toronto. We have not had one stroke. Now, if you correct what are called confounders, now we know that stroke occurs more commonly, say, in people who smoke. You have to, as a scientist and a statistician, you need to control when you're looking at results. Are we controlling for something that might also cause the same thing as the treatment? So if one group has a lot of smokers in it and another group doesn't, you're not comparing apples and oranges. You're not comparing apples to apples, you're doing apples to oranges. And one group is naturally going to have a higher risk because they have a lot more smokers in it. So when you do that, and you control for confounders. In this study with over 4,000 patients, they couldn't see a difference. And that's been my experience too with the conformal radiation, that I have had some patients who had conformal radiation, not just for pituitary, but other diseases that we treat. And by and large, all the patients who had strokes were smokers. Now, acromegaly is an important issue because hypertension, as we've heard, high blood pressure, and diabetes are also risk factors for stroke. So we need to take that into account. Now, when they look specifically at gamma knife for acromegaly, the stroke rate was not increased when they compared it to an equal group of patients who were matched in the population. So age is another factor. The older you are, the more likely you are to get a stroke. So you need to match on all these confounding factors. So it doesn't look like for gamma knife that stroke is not increased by the treatment. It doesn't mean that a person won't get a stroke, because if you smoke, you have high blood pressure and diabetes, you're at risk of stroke. But what I'm saying is that the addition of the gamma knife isn't going to make you more likely to have a stroke. Okay? Now what's clear, if we give more than one dose of radiation, let's say it fails and we have to give again, there's a higher likelihood that you're going to get into visual problems. So we don't like to give this treatment more than once. Okay, and I can tell you if we have to do the surgery again, the surgery is a higher risk. So we kind of want to get the best option that we can, and that's why I say it has to be individualized. Now, what about this question of losing your hormone function? I've heard that, Jill told me yesterday about a story of a person who ended up dying because they didn't recognize that they lacked a hormone. And I've been called into ICU in a big downtown hospital. I won't tell you what city. And the patient was in a coma. And the person had fallen. They had a little tiny area of blood there. And they asked for a consultation. What's going on? And, should you take person's skull off to relieve the pressure in their head? Because the person not waking up. And to make a long story short, the person was lacking hydrocortisone. And so I said, give me the syringe with the hydrocortisone. Gave the syringe and the person woke up. Okay? So people, hypopituitarism, the lack of these hormones is life-threatening, and it's really important that people take their medication. Okay, this was a study looking at, again, it's an old study, so they had, look, 1967 here. So these are children generally who had craniopharyngioma, which is not a pituitary tumor, but it's in the same area. And they followed these patients for 10 or more years. And you can see that 5% of them, they died of endocrine problems. So this highlights the need that people take their medication, that their caregivers know, and that they, again, get literate and do things like get a medic alert bracelet. Because hydrocortisone, the pituitary is the last thing that doctors think about. Okay? So if you're going to get on any treatment, whether it's surgery and you lose your hormone or the tumor has knocked out the hormones, one take-home message is that, and every endocrinologist knows this, you have to take your medication, and when you get sick, you have to go on the double dose. So you double the dose of the medication. And every endocrine unit that I've ever worked with is very clear on that with patients, but we can't emphasize it enough, especially in countries like Canada, where English might not be the first language. People have differing levels of education. We have this healthcare system, but there are a lot of barriers that still exist. poverty exists, and there are groups that are more able and less able. So we need to give our care to everybody. So I'll just go through a couple of quick case studies here. Here's the first one, a young woman with typical acromegalic features. We tried to debulk this tumor. We had no preconceived notion we're going to get it all out, but the tumor was very firm and rubbery. Most tumors are soft, but about 1 in 50 tumors are like a hard rubber ball, and the surgeon can't do that much. It's too big for a gamma knife, okay? So radiation's an option, but the patient's very young, and we're going to be radiating a big amount of brain. So we refuse that patient. Patient goes on to medical therapy. Here's another patient, 45 years old. Typical changes, change in the body habitus, sleep apnea, and we did surgery. And contrary to what you heard yesterday about cavernous sinus, we routinely open the cavernous sinus. It's not something that an inexperienced group should ever do, but if you have experienced surgeons, you should do it all the time. So we excised the medial wall of the cavernous sinus right up against this artery, and the patient had excellent outcome. Okay, and you can see this growth hormone. So here's the MRI, and before and after, and you see the hole there. So that patient doesn't need it. Here's another patient where there was a worry about doing surgery because the carotid arteries were very close together. And so traditionally they said, well, I can't do the surgery. But the patient had heart disease, sleep apnea, early diabetes. And the patient, wasn't really too keen, but underwent the surgery. Here's the tumor, and then afterwards. And then this patient had good biochemistry as well. So that case is not a good case. You don't need to do gamma knife. But this particular patient's 42 years old. Actually, the dentist found this diagnosis out. The patient had undergone, his jaw was getting bigger and bigger, and had a jaw surgery because the lower jaw was jutting out too much. And within a year, it was starting to come back again. And so the dentist actually suspected acromegaly. And then in retrospect started asking about changes in the fingers and hands and feet and other things, and it was diagnosed. Okay? And so here's the tumor, here's the artery, and this is the cavernous sinus. Okay? So we operated on the patient, but we weren't able to get all the tumor out. You can see here that there's less tumor, but there's still some tumor, and when you look at the blood work, this growth hormone, it should be lower. Okay, the IGF-1 is still too high. So even though there's a little bit of tumor, this patient needs treatment. That patient is a perfect patient for gamma knife because the pituitary gland is far away. It's a very isolated area to treat, and that patient did very well. So this patient was accepted. And so this is the treatment plan, and these lines are where the radiation dose is going. And so these are the high doses right here where the yellow is, and then it drops off very fast. By here, it's already half the dose. So it's very focal. And you can see here, and even though the carotid artery is right there, the brain here is getting almost no dose, very low, not zero. Don't misunderstand me. It's not zero. And we did do a study. This is the memory part of the brain called the hippocampus here. We did a study looking at memory. in patients who got gamma knife, not just for pituitary, but other tumors in this area as well nearby. And what we were able to show was that those patients, when we did a 3-hour memory and psychological testing on them, actually did get worse. But they got worse and they recovered within about 6 months. So when patients tell us, look, my memory's worse, like Dr. Van Oom was saying, we need to listen to that because it's real. We may not be an expert in memory. Well, neuro people should be more expert than the endocrinologists, but we're not psychologists. So it behooves us to get those people involved who we need to do. So I think the message here is that the gamma knife and the radiation in general needs to be chosen selectively, just like other treatments. If it's in the cavernous sinus, especially if they've already had loss of hormones and the gland is far away, about half of the people will get a response in terms of endocrine hormone. About 20 or 30 might need hormone replacement. There's a small risk of other, very small, in the 1 or 2, under 5% risk that we could get some mild effect on other things like vision. And we need to educate people. And certainly if there's an issue about ability to pay, which we can't ignore, as we heard Dr. Wong yesterday, the Canadian government is coming around, and 1.5 billion sounds like a lot, but at $600 a day for one patient, 1.5 billion gets eaten up pretty fast. And many patients around the world have no access to money like that. Then I think it's a very, very valid use. And it can maintain quality of life. It's not perfect, and neither is surgery and neither are medications, but it can be very, very life-saving. But it highlights again the need for us, again, to get to early diagnosis. Do you want me to say a few words about that, or you want to move on? And
yeah, we need to jump to the next.
Okay, so I just want to encourage you to participate in that study I mentioned yesterday. They've got the handouts there, and the key is going to be up to you guys to make it a success. And Canada, I hope, will be a leading group around the world to make this a reality, and that will help people down the road, that they don't have to go through the same suffering that every one of you have experienced, and we make a change for the future. So thanks again to Deanna and all her team for organizing this. It's a massive amount of work, and I appreciate spending the time with you, and happy to be with you.